Thanks everybody for joining us today for our very last session of the Upgrade Oncology Pathology series. I just wanted to thank all of you so much for sticking in there and joining us to listen to these sessions. As you know, the recordings are available in perpetuity at that link that we've been sending you all month, and we'll send you a reminder at the end where you can access that link to watch any of the sessions that have already been previously recorded. Today, as always, if you have questions, please put them in the Q&A box, and they will answer the questions at the end of the second lecture. If you have a technical problem, please put it in the chat. We have two speakers today. They have two separate presentations, but we've already tested them, should be fine. Our first speaker is Dr. David Meredith, who is an assistant professor at Harvard Medical School and a neuropathologist, and he will be followed by Dr. Sandro Santagata, who is an associate professor at Harvard Medical School and also a neuropathologist. At the conclusion of the series, we will work with Runcie and Gloria to get certificates for everyone who participated, so you can document that you were here for the webinar series or that you watched them of the recordings online. But with that, I think I will turn it over to Dr. Meredith to begin.
Thanks so much, Danny. This is an exciting opportunity to share our expertise in the area of neuro-oncology and neuropathology. And so my presentation is going to be on a broad overview of mostly adult gliomas, and hopefully we can kind of establish a foundation and working knowledge for this tumor type, and maybe broach on some higher level concepts that have started to permeate most of neuropathology. So once upon a time, most tumors were classified on the basis of their resemblance to normal anatomic constituents within their respective tissues of origin. And that really formed the foundation for the practice of neuropathology. So as tumor class must first be assigned based on the histologic appearance. Only then could a tumor grade be issued, and each tumor class had a specific set of rules for grading. Here's an example from a couple of iterations ago from the 2007 WHO. And once a grade had been assigned and a tumor class had been issued, only then could a specific treatment and prognosis be offered. And so within this branch of gliomas, there are really two main subtypes that we consider. Those are the diffuse gliomas, which are by far and away the most common, especially within the adult practice. These include tumors that are diffusely infiltrative throughout the brain tissue, mostly include astrocytoma and oligodendrogliomas as the subtypes. Morphologic diagnosis is somewhat limited due to their fairly high degree of morphologic overlap, and they're of course incurable and prone to progression as time moves forward in the natural history for those. The non-diffuse category of tumors we'll largely not consider today. They're much more rare and more confined to the pediatric treatment space, but those include tumors such as ependymomas, pilocytic astrocytomas, a variety of glioneuronal tumors, etc., which by and large are not as infiltrative throughout the brain tissue. Unlike a lot of other aspects of anatomic pathology, lineage markers in brain tumors are of somewhat limited utility. While there are markers that are somewhat specific for various cell types within the non-neoplastic brain, such as GFAP within astrocytes and OLIG2 as a master transcription factor regulator for oligodendrocyte lineage. Both of these markers are largely positive in all glioma types and are thus not useful in a classification setting. Similarly is true for ependymal markers and neuronal markers, and we've kind of rapidly adopted the axiom that light microscopy alone is largely insufficient for full diagnosis. Over time, as molecular diagnostic technologies have become more and more high resolution and comprehensive in whole genome, there have been a number of studies that have been put together that have allowed for comprehensive profiling of tumors and sort of the categorization of various tumor types on the basis of their molecular profiles. And this was really solidified in the 2016 edition of the CNS WHO, in which a number of entities received histomolecular definitions and really required ancillary molecular testing for their classification. This has only exploded in 2021, the most recent CNS WHO, which now has a whole host of characteristic markers and definitional gene alterations that accompany the vast majority of entities in the WHO at this point. And my goal today is not to go over all of these, but rather just to point out the fact that the infiltration of molecular testing has become rather complete in our subspecialty. So now our new diagnostic workup in neuropathology really not only includes traditional histologic examination, but integration fairly tightly with a variety of molecular data from next-gen sequencing to more single gene assays to allow for a integrated diagnosis and more personalized treatment regimen options. So let's move into more current considerations for diffuse gliomas. Back in 2016, once the integration of IDH mutation status and 1p19q co-deletion status were integrated in the workup of diffuse gliomas, the following flowchart was arrived at, kind of a practical workup for these tumor types. So based on the histologic subtype, one could then branch off into whether the tumor showed IDH mutation status or not, and if so, then accompanying other mutations or 1p19q co-deletion status could be integrated to arrive at specific top-line diagnoses. And those tumors that were IDH wild type were largely considered glioblastoma. And in the event that genetic testing is unavailable or inconclusive, then one could rely on a less specific histologic set of diagnoses with a not otherwise specified moniker at the end. And the integration of these two molecular markers really cleaned up a lot of the prognostic data for diffuse glioma subtypes, shown here in this seminal paper from 2015 looking at TCGA data. The original histologic-based classification criteria did a pretty good job of substratifying the natural history for a variety of tumor types. However, when considering 1p19q and IDH mutation status, now if we look at low-grade gliomas, in their definition, low-grade meant grades 2 or 3. Relative to grade 4 tumors, one could see that all IDH wild-type tumors, irrespective of histology, essentially overlapped in terms of their survival behavior, whereas those with IDH mutation status performed far better. And so since integrating this, we can really, allow a fairly small triage workflow to be incorporated into our histologic workflow to arrive at diagnoses that integrate these two biomarkers. We rely fairly heavily on IDH1 R132H immunohistochemistry, which captures about 85 to 90% of all of the IDH mutations that are present in these tumors. And then 1p19q status, either via FISH or some other technology. We can also use some other immunohistochemistry, which I'll show in a moment, to subdivide those IDH mutant tumors, and then everything else essentially kind of belongs in the glioblastoma camp. So let's transition briefly and talk about some of the characteristic histologic features of these tumor types before we kind of dive back into the integrated discussion. Oligodendrogliomas, which are among the better behaving diffuse gliomas, are fairly uncommon. They're essentially non-existent in children. There are a variety of pediatric glioma types that have oligodendroglioma morphology, but are not IDH mutant or 1p19q co-deleted tumors. They tend to behave better than other diffuse glioma types. Their highest grade that is allowed is grade 3, so there is no grade 4 for oligodendroglioma. And as with most diffuse gliomas, they tend to be centered in the white matter and be subtly expansive mass-like forming lesions that can cross over white matter tracts, such as the corpus callosum in this coronal brain section image. Histologically, they have very characteristic fried egg cellular appearance, kind of a monomorphic rounded nucleus with perinuclear clearing. That's an artifact of formalin fixation processing. And one can see that the tumor cells are fairly evenly distributed throughout the tumor, and there's this presence of abundant, delicate, almost chicken wire branching vasculature within the background. For low-grade oligodendrogliomas, sporadic mitotic figures less than 6/10 high-powered fields are allowed for grade 2. And when including other immunohistochemical panel, usually ATRX is retained and P53 is low. And I'll show you an example of this coming up. At the time of frozen section, a smear preparation will tend not to show those cleared perinuclear cytoplasmic features. Instead, the cytoplasmic processes are very finely fibrillar in contrast to the coarsely fibrillar processes of astrocytic tumors. The nuclei are very rounded and monotonous, and it can also sometimes have this almost icy appearance with the microcystic appearance in the background that can occasionally freeze and cause ice crystal artifact at the time of the section, not the smear preparation. But usually this is not a diagnosis we offer at the time of frozen section due to the lack of the characteristic histologic features. Like most gliomas, oligodendrogliomas have a propensity to diffusely infiltrate through the white matter and up into the cortex. This is a nice image showing the junction of the white matter, which is down at the bottom portion of the panel. Tumor cells are diffusely infiltrating up and aggregating around blood vessels and around neurons, a feature that's known as malignant satellotosis. This can sometimes be a very helpful clue when a limited biopsy is present. And sometimes we only have superficial biopsies at the time of frozen section, and the presence of a supernumerary satelliting glial cells around neurons and vessels can sometimes be the clue that one is at the edge of an infiltrating glioma. And here's an example of a normal picture of cortex showing a pyramidal neuron with occasional satellite cells that show the phenotype that these tumors are trying to recapitulate. Similarly, they can have a propensity for a leptomeningeal spread. Here's the cortical leptomeningeal junction right here in the right panel, and one can see the tumors diffusely crawling through the leptomeningeal space. And this is the corresponding normal image to give you a comparator. Oligodendrogliomas and most IDH mutant tumors in general can have microcystic appearance, which can be variably prevalent. And oligodendrogliomas are also notorious for forming microcalcifications, which can sometimes be a clue even on pre-surgical imaging, but is by no means a specific finding, as these can be present in a variety of other low-grade gliomas, many of which have other genetic alterations. Oligodendrogliomas can also occasionally show kind of a mixed phenotype. Once upon a time, we had oligoastrocytoma as a diagnostic entity that had mixed features between astrocytic tumors and oligodendrogliomas. Tumors which are genetically oligodendrogliomas can occasionally show regions that are fairly dense in these mini gametophytes, cells that are trying to recapitulate reactive astrocytes in the normal brain, but they're much smaller than what you tend to see in IDH mutant astrocytomas. Here's a GFAP immunohistochemistry showing some of these cells with their stumpy processes and minimal eosinophilic cytoplasm corresponding to the H&E. On grade 3, to assign grade 3 to oligodendrogliomas, there aren't great hard and fast cutoffs from a histology perspective. Mitotic count cutoffs of greater than 6 per 10 high power fields have been offered. These tumors can also occasionally present with microvascular proliferation and necrosis, just as other high-grade gliomas might. More recently, the presence of homozygous CDKN2A deletion has been offered as a surrogate biomarker for grade 3 behavior in oligodendrogliomas. But in the absence of CDKN2A deletion, the grading of oligodendrogliomas can be fairly fuzzy and of occasionally limited utility. The survival of these tumors is far and away better than the astrocytomas, even at comparable histologic grades. When present at grade 3, oligodendrogliomas are considerably more cellular. Sometimes they can even resemble lymphomas due to their high NC ratio and round cell appearance. They can present with microvascular proliferation, as I showed earlier, so multi-layering of the endothelial cells within the tumor proper or right at the edge, and occasionally there can even be palisading necrosis. That tends to be uncommon. Moving on to astrocytomas, low-grade astrocytomas tend to be an uncommon diagnosis. They're usually present when an IDH mutant mutation is present in the tumor as well. They can be fairly subtle on the edge of the spectrum. These tumors can occasionally be indistinguishable from normal or reactive brain tissue. The cells themselves tend to show greater nuclear pleomorphism and hyperchromasia relative to oligodendrogliomas. There tends not to be that even spacing between cells. You can occasionally see clustering of nuclei. And they can also have a more predominant gammasticitic appearance. So whereas we saw the miniature gammastocytes in the oligodendrogliomas, astrocytomas tend to have more fulminant gammastocytes, meaning the cytoplasm is more abundant and occasionally can show epithelioid or rhabdoid type forms. As I mentioned, most low-grade astrocytomas tend to be IDH mutant. And this quartet of immunohistochemical stains can really help the distinguishing between the two classes of astrocytoma and oligodendroglioma. So the IDH1 R132H immunohistochemical stain, mutation specific stain, is very helpful when trying to make this diagnosis. It nicely shows both cytoplasmic and nuclear positivity in most instances. ATRX is a constitutively active gene, and when mutated, produces an alternate lengthening of telomeres phenotype and will be lost within the tumor cells. So one just sees retained staining in background normal architecture, such as vessels and background glia. And then most of these tumors have P53 mutations, and the specific mutations are often missense inactivating mutations, which mean that the protein continues to be expressed and upregulated. And as a result, the immunohistochemical pattern shows strong and diffuse staining throughout the tumor cells. There can occasionally be deletion mutations, in which case the stain would be completely negative, but that's a much more difficult instance to interpret. But this pattern, this triple mutant pattern of IDH, P53, and ATRX is highly consistent with an astrocytoma lineage and can be used in absence of 1p19q testing when the histology and immunohistochemical profile matches. At smear preparation, astrocytomas, as I alluded to earlier, have a more coarsely fibrillar appearance. This can be very, very helpful when non-glial tumors are present in the differential at the time of frozen section. These are essentially the only tumor type that are going to show this nice stringy cytoplasmic processes. The nuclei are very consistent with what we've seen in the permanent sections, pleomorphic hyperchromatic nuclei, and occasionally those gammastocytic forms can be seen as well. Higher grade astrocytomas will show mitotic activity with the absence of vascular proliferation or necrosis. So a strict grade 3 criteria will only allow for increased mitotic activity, usually something on the order of greater than 1 or 2 mitotic figures per 10 high power fields will qualify for grade 3. And as I mentioned, no vascular proliferation or necrosis. Bona fide grade 3 astrocytomas are also reserved for IDH mutant tumors, as I'll touch on in a minute. Those that do not have IDH mutations are now all considered grade 4. Speaking of grade 4, glioblastomas tend to be far easier to recognize. They show much more malignant growths and histologic pathology. So on cut sections of involved brains, one can see hemorrhage and necrosis and obvious infiltration throughout the white matter and cortex. Here's a nice kind of butterfly appearance where the tumor is crossing through the corpus callosum to the other hemisphere. Here's another coronal image showing similar features. The hallmarks of high-grade features in astrocytomas and in most gliomas in general are, as we've touched on before, but palisading necrosis, which is lined by this almost picket fence-like arrangement of tumor cells, and then microvascular proliferation, which can approach glomeruloid type configurations in some instances. And this is the basis for contrast enhancement on imaging. These vessels do not establish a tight blood-brain barrier and allows the contrast medium to leak out into the surrounding brain tissue, allowing for that contrast enhancement profile on imaging. So this is really the histo correlate to that radiologic finding, which can be very helpful to review prior to looking at our pathology sections. A smear preparation, glioblastomas show essentially the same features as other astrocytic tumors, except they can just have more pronounced pleomorphism, cellular density, and necrosis and mitotic activity as well. I briefly wanted to touch on a few histologic subvariants of glioblastoma. We've dropped the multiform second half of the moniker from the title, but it was nice to remind folks that this tumor really can show a wide array of morphologic appearances, and some of these are worth highlighting. So the giant cell variant, just as the name suggests, is really composed predominantly of giant cells, some of which can be extremely large, hundreds and hundreds of microns across. Most of these tumors will also show abundant geographic necrosis. Inflammation can be fairly prominent in some examples. And it's just worth pointing out that some of these tumors can show mutations in both ATRX and P53, which can occasionally cause confusion. These are not IDH mutated tumors, and so they should not be confused as such. But occasionally, if one is running an immunohistochemistry panel and sees mutant patterns for ATRX and P53 within this general histologic appearance, do not presume or suggest the presence of an IDH mutation. I'll also mention that with rare exception, most of these histologic variants have no prognostic significance whatsoever. All of these glioblastomas essentially perform equally poorly, but they just have a particularly evocative appearances that may occasionally be confused with other tumor types. Some high-grade astrocytomas can show what's now referred to as a primitive neuronal component. In the past, these would occasionally be referred to as glioblastomas with peanut-like features or embryonal features. And just like embryonal tumors, they can express strong positivity for neuronal markers such as synaptophysin and have absence of GFAP, which can clearly cause some confusion. This can happen in both IDH wild type and mutant high-grade astrocytomas. And the clinical pearl here is that although studies are still in progress, there's some indication that these tumors have a predisposition to produce drop metastases elsewhere in their neuroaxis, just as other embryonal tumors may. And so these, the presence of this morphologic component, which can occasionally be focal within tumors, may warrant more aggressive radiation therapy, such as whole brain or brain and spine radiation. Finally, epithelioid GBMs can have very prominent epithelioid or even rhabdoid morphology. These are frequently associated with BRAF activating mutations, although they're certainly not present in all of the cases. There's been some debate as to whether these tumors represent true anaplastic pleomorphic xanthoastrocytomas. Those are more of a pediatric type circumscribed glioma with BRAF alterations that predominate. But those tumors that warrant glioblastoma designation usually possess other molecular features of glioblastoma, such as TERT promoter mutations or the combination of polysomy 7 and monosomy 10. So this can occasionally crop up. It should spark testing for BRAF either via immunohistochemistry or whatever assay is available, and may predispose to some kind of targeted therapeutic response. Gliosarcoma is a fairly interesting subtype as well. These tumors have regions that can be variably prominent that have frankly sarcomatous appearance, spindle cell morphology with variable amounts of collagen that usually are negative for glial markers and show diffuse positivity for reticulin. So here's an interface between a sarcomatous and more glioma component. And they can also have a variety of heterologous elements as well. Some can form bone. Here's an example in panel B. In panels ENF, there's chondroblastic differentiation. There can even be angiosarcomatous or even epithelial differentiation within these tumors. So anytime one runs across that kind of morphology within a tumor that otherwise might be considered glial, this is something to consider. And there are no distinct molecular features of this morphologic pattern. It's just can obviously be confused with either metastatic or primary brain sarcomas. So just kind of jumping back to the immunoprofile for these three tumor types, oligodendroglioma, astrocytoma, and glioblastoma, looking at our three main immunohistochemical markers that we have at our disposal. IDH R132H should in most instances be positive or show a mutant pattern in oligos and astrocytomas and be negative in glioblastomas. These are by definition IDH wild type and should be negative. ATRX will be retained in oligodendrogliomas and usually retained in glioblastoma. There are some exceptions, as I indicated earlier, but when present with IDH positivity is usually a clue that this is an oligolineage tumor, whereas it's nice and lost in astrocytomas, the vast majority. There are some instances where ATRX will be retained in astrocytomas. This is not a 100% sensitive stain, but in about 90 or so % of cases, it will show this nice mutant pattern. And P53 will show the inverse. For oligodendrogliomas, there's usually just a wild type or kind of reactive pattern with rare, faintly positive cells. Astrocytomas will generally show a strong and diffuse mutation pattern. And glioblastomas can show either or. I think about 30 to 40% of glioblastomas will have P53 mutations, so it's not a very reliable marker in this setting. And even though 1p19q is highly recommended for testing in the setting of an IDH mutant tumor, because of the specificity of ATRX loss and frequent P53 positivity in tumors that show convincing astrocytic morphology, positivity for IDH R132H immunohistochemistry, and a mutant pattern for ATRX and or P53, those tumors can be confidently classified as a astrocytic tumor without needing to reflex to some sort of cytogenetic testing for 1p19q. If there's any kind of discrepancy or confusion with the morphology, this is best left as a non-specific grade or non-specific diagnosis while the molecular testing is pending. But when everything matches nicely, one certainly does not have to wait for 1p19q testing to offer a definitive diagnosis. It is worth pointing out, however, that not all IDH mutations occur are the specific missense mutation. It only captures about 90 or so %, as I mentioned. And oligodendrogliomas have a higher percentage of non-canonical IDH mutations. So these would be tumors that have either different missense mutations at that R132 codon in IDH1 or IDH2 mutations at the analogous R172 codon, which typically are not picked up by most IDH antibodies, certainly not by the single mutation specific antibody. And the pan IDH1/2 mutation antibodies tend not to pick up these specific mutations. So it's not very reliable in some instances. So if the morphology fits with oligodendroglioma and the IDH stain is negative, but shows the wild type patterns for ATRX and P53, one can certainly suggest that it is an oligodendroglioma, but this is a scenario where some other form of IDH testing, whether that's PCR or next-gen sequencing, would be recommended along with some mechanism of 1p19q detection. And 1p19q is usually mediated by an unbalanced translocation. One can see a representative karyotype of these chromosome derivatives. And as such, FISH has been a useful test for this event. However, it's worth noting, looking at this brief heat map, so we're seeing the genetic real estate on chromosome 1 and 19. Blue is indicative of chromosomal loss. One can see that in astrocytic tumors that have IDH mutations, they can occasionally have telomeric deletions of 1p and or 19q. You can see some of these thin blue regions that are highlighted by the yellow box. And this is where the commercial FISH probes recognize. So if there is a whole arm deletion than the most commercially available FISH probes would yield false positive results. We're really interested in whole arm 1P and 19Q co-deletion, not partial loss of either. So that's something to be aware of. And many labs, although it's certainly not available everywhere, are beginning to transition to some form of broader test, whether that's by an array. So this is a chromosomal microarray visual output. So at top here, we're looking at log2 values. So a diploid region of the genome is right here at 0. And all the deviations below that are representing copy number losses. So one can see in a more genome-wide assessment, 1P and 19Q can be more reliably assessed. And furthermore, most gliomas show fairly stereotypical chromosomal alterations, specifically glioblastomas as well, which have trisomy of chromosome 7, monosomy of chromosome 10, frequent EGFR amplifications. And these features can be used to make the diagnosis of GBM, even if the histology isn't quite all there. So being able to routinely assess broader copy changes is of increasing utility in this subset of neuropathology. So since neuropathology is transitioning so hard towards integrating molecular testing, both in the top line diagnoses and for supportive diagnostic criteria, we've begun to create guidelines for reporting these integrated diagnostic outputs. So the International Society of Neuropathology in 2014 issued the following recommendation for a 4-tier reporting system, where one includes the traditional histologic classification, so whatever it looks like under the microscope, whatever relevantly present molecular information, whether that's by immunohistochemistry targeted or more broad assays, and then an incorporation into a combined integrated diagnosis and overall WHO grade. So for example, here's an embryonal tumor that largely is nonspecific and has some rhabdoid features, and it has loss of INI1. So in the descriptive setting, we would just call this an embryonal tumor with rhabdoid features. But since we have the definitional loss of INI1, which makes the criteria for an atypical teratoid rhabdoid tumor, we can now issue the specific diagnosis. And if the immunohistochemistry were negative or just not available, we'd be left with a descriptive diagnosis. Same thing's true with an ependymoma. I'm not going into this further, but we're now highly relying on methylation analysis for classification and grading of these tumor types. So, if we didn't have sufficient tissue for further analysis of this tumor, we just be left with a descriptive anatomic and morphologic pattern, and then a WHO grade based on that histology. So for many examples that we run across in routine practice, I'm showing 3 examples here. On the left is a high-grade glioma. Here's a densely cellular tumor with some palisading necrosis. In the middle is a more paucicellular tumor that has some features of astrocytoma, but there's some cells that are kind of rounded with perinuclear clearing, so it's unclear what the definitive class is in this setting. And on the right is a tumor that may end up being a pilocytic astrocytoma, but we usually have limited material and maybe not all of the histologic features are there. Some coarsely fibrillar cytoplasmic processes. Here's a Rosenthal fiber, et cetera. But we'll just kind of leave it with a descriptive diagnosis. Once we receive ancillary molecular testing, so on the left example, we have a TERT promoter mutation, no IDH mutations, and characteristic GBM findings. And so that allows us to confidently call this an IDH wild type glioblastoma grade 4. In the middle, we can see that this is an IDH mutant tumor that has mutations in both ATRX and P53. There's no co-deletion of 1P19Q, so we know this is an astrocytoma. Furthermore, there's no negative prognostic markers, and so we can both classify and grade this tumor now as an IDH mutant astrocytoma. And then this example on the right has a BRAF fusion. So in combination with the suggestive pilocytic astrocytoma features, we can now confidently make that diagnosis. So this kind of touches on the idea of integrating molecular features to help us grade tumors. As we saw back earlier in the talk, once 1p19q and IDH mutations were integrated into classifying diffuse gliomas, we saw that low-grade IDH wild-type tumors were very, very aggressive, much more so than IDH mutant tumors, suggesting that grading of those may not be so helpful. And in fact, that's proven to be true in other scenarios as well. So most notably in the 2021 CNS WHO update, IDH mutant gliomas have been the beneficiary of a number of changes, so that there's a simplification to the nomenclature. We don't have separate names for the different grades. All tumors are just listed by either Astrocytoma IDH mutant or Oligodendroglioma IDH mutant and 1p19q co-deleted, and then a grade assigned at the end. So that simplifies the naming features. And then studies have shown that amongst the various molecular markers that can be found in these tumors, only CDKN2A homozygous deletion can be used to upgrade a tumor irrespective of histology. So in this, this publication from 2018, one can see that tumors that had a variety of histologies, so in this case, grade 3 and grade 2 tumors that were IDH mutant that did not have CDKN2A loss behaved more or less equivalently, whereas those tumors that were either grade 3 or grade 4 and had homozygous CDKN2A deletion were very, very aggressive. So this has really allowed us to refine our grading criteria for these tumors, and the same has been shown with oligodendroglioma. So if the histology is not terribly impressive, but one finds CDKN2A homozygous deletion, upon molecular testing, one can certainly revise the grade to a grade 3 and more accurately capture the biologic potential of that tumor. So here's an example. This was a real life example that I myself had a number of months ago. It's a tumor that looks like it's an astrocytoma. There's some nuclear pleomorphism and hyperchromasia. The tumor cells are not terribly evenly spaced, but we don't really see too many mitotic figures. I know it's not the highest magnification image, but you can take my word for it. And no definitive vascular proliferation or necrosis. So I diagnosed this as an IDH mutant astrocytoma grade 2. We did our molecular testing, and what we found was that, again, this is a log2 plot. So we're seeing all of these regions that are right around 0 are all normal or diploid regions of the genome. And those that are deviant from that diploid state are highlighted in this green color. And right here in chromosome 9 is a 2-copy loss of CDKN2A, very focal. And here's the mutation information from that assay. So now with the molecular information, we can revise the diagnosis and issue an integrated diagnosis of astrocytoma IDH mutant grade 4. Helps the clinicians address that behavior a little more accurately than just sitting and waiting, perhaps, if the tumor is not so aggressive. Revisiting these quote-unquote low-grade IDH wild-type gliomas, as I mentioned earlier, these are the tumors in this red survival curve that overlap almost exactly with proper IDH wild-type glioblastomas. The CIMPACT Now interim WHO working group issued guidelines that if these tumors show either grade 2 or grade 3 histology, but are IDH wild type, so no mutations in IDH 1 or 2, and also show one of the following features, so EGFR amplification, gain of 7 and monosomy of chromosome 10, and or TERT promoter mutation, they can effectively just be labeled as glioblastoma grade 4. And that more accurately captures their biologic potential and greatly helps oncologists with enrolling these patients into clinical trials that are best able to treat their tumor. So here's another example, another real life example that we had a few years ago. This was an elderly woman who presented with fairly nonspecific neurologic symptoms, had a fairly indistinct T2 hyperintense lesion in the deep white matter. It was not mass forming at the time. It was unclear if it represented neoplastic or non-neoplastic etiology. And at the time, the biopsy showed what was largely indistinguishable from normal brain. There's maybe a few too many cells. Here's some that are clustering together, which is unusual for normal brain tissue to do. So it's certainly suspicious for there being a present infiltrating glioma, but we decided to hold off making the definitive diagnosis until we had more molecular information. And in essence, what we found was that there was a very subtle gain of chromosome 7 and loss of chromosome 10, along with some other genetic aberrations. There's also a P10 mutation. So we're not only confident that this was in fact a tumor, but in the absence of IDH mutation, we can now call a tumor that was almost undiagnosable as being neoplastic, now grade 4. And some of you may ask if this is, an appropriate diagnostic practice. And so this is the rare instance in which the very same patient was operated on 4 weeks to the day later when she had a ring-enhancing centrally necrotic lesion that had all histologic features classic of glioblastoma. So now this is that same tumor in the same area where this biopsy was originally obtained. So the biologic potential of these lesions is clearly highly aggressive and essentially tantamount to glioblastoma. So this workflow allows us to capture those more directly. I now want to transition and talk a little bit about pediatric low-grade gliomas. These are certainly not a common specimen type, I think, in most centers, unless there's a children's hospital component or affiliate. But they're worth talking about since some of these bleed over into the adult practice at the kind of younger age range. There are a whole host of morphologic appearances of pediatric low-grade gliomas. I certainly don't want to go into all of them today, mostly just to point out that some tumors can show morphologies that overlap tremendously with adult tumors, and then others, such as the more classic pilocytic astrocytomas and some other glioneuronal tumors, have very distinct morphologies. But by and large, they're a highly common tumor type within the pediatric population, and they can occur throughout the neuroaxis. What's unique about these tumors is that unlike adult gliomas, they really are far more indolent. So those tumors, kind of irrespective of histology, low-grade diffuse gliomas that receive gross total resections behave very well at long-term follow-up studies. And most of these tumors are driven by different molecular drivers. Most of them have alterations in the MAP kinase signaling pathway, which not only confers a different biologic potential, but also means that there are many more opportunities for targeted inhibition. Attempts to solidify different morphologic appearances with different molecular events clearly leads to a very muddy table very quickly. And this kind of recurrent or promiscuous gene alterations within this class of tumor type has essentially led to the abandonment of assigning specific diagnoses in many instances. So again, a C-Impact Now update a couple of years ago essentially recommended that low-grade diffuse gliomas in children not bother assigning a definitive top-line diagnosis. Instead, name it something nonspecific like diffuse glioma, and then list the characteristic alteration. And this has really been a trend, I think, taking over a lot of pediatric neuro-oncology, because in most instances, low-grade gliomas, whether they show diffuse or circumscribed histology, have very similar biologic potentials. In other words, they can be extremely indolent and they do not transform. So the need for a specific diagnosis is less and less pressing in that space. And then furthermore, listing the genetic driver gives the oncologist information to help with treatment should a specific inhibitor be available. In the current WHO, pediatric low-grade gliomas and glioneuronal tumors have been binned into 3 different types. Again, my goal is not to go into all of these, but just to make you aware of how these tumors are divided up. So there's many instances in which there's a non-specific nomenclature, so diffuse astrocytoma with an MYB or MYBL1 alteration, diffuse low-grade glioma with MAP kinase pathway alteration, and then many other kind of descriptive entities as well. By and large, with some exception, these are all grade 1 tumors, and many of them have fairly specific molecular alterations. And here's some examples of some new tumors that have been introduced in the current WHO. Some that have fairly characteristic histologies, such as this polymorphous low-grade neuroepithelial tumor of the young, which is a fairly lengthy diagnosis that's often abbreviated as a PLNTY, has a somewhat oligo-like appearance with more nuclear pleomorphism. There are tumors that have features that kind of overlap with other entities. So this myxoid glioneuronal tumor, for example, has a lot of features that are characteristic of a dysembryoplastic neuroepithelial tumor, but instead of occurring in a cortical location, occur more periventricular and have different genetic alterations. And then some tumors that may be more hamartomatous, such as this multinodular and vaculating neuronal tumor that can cause epilepsy, but otherwise doesn't pose too much problems in these patients. So many tumors that have, in some instances, characteristic morphology, in some instances not, but most of them have genetic features that have been delineated for them. I just wanted to quickly mention that if one is doing an assay that assesses copy number alterations, whether that's for other purposes, most of the genetic rearrangement events that occur in pediatric low-grade gliomas are the result of intrachromosomal duplications or deletions. So the BRAF fusion that's characteristic of pilocytic astrocytomas, for example, can be pretty accurately diagnosed with a copy gain that occurs intragenically within BRAF, similar for other fusion events that are characteristic of other tumor types. So that can occasionally yield additional information that are helpful. I purposely wanted to include this convoluted diagram at the end of this section to show how there's been multiple efforts to do sequential or single gene analysis for the diagnosis of these pediatric low-grade gliomas, and everything kind of ends with next-gen sequencing, option at the bottom of the flow diagram. And this is really where I think these tumors are moving. So whether it's an RNA-based or DNA-based assay, most of these pediatric gliomas will need some kind of sequencing analysis for complete diagnosis. I briefly want to talk about pediatric high-grade gliomas before we transition to our next topic. Unlike adult tumors that are driven by copy changes or IDH or EGFR type alterations, these tumors have very different drivers. In particular, those that have histone mutations we'll discuss briefly. So some tumors occur remarkably specifically within midline structures, such as spinal cord, brainstem, cerebellum, deep nuclei, etc. And those frequently have histone 3 lysine 27 mutations or other genomic events that modify the methylation of this residue. And then other tumors are more hemispheric in locations that have a different codon mutant, in this case, a G34 mutation, which occurs, as I mentioned, with those hemispheric gliomas. And the natural history of these tumors it tends to be fairly aggressive, and in many cases overlaps with an IDH wild type glioma in adults. So they're highly aggressive, lethal tumor types. Histologically, if we look at those hemispheric gliomas with the G34 mutations, these can be kind of confusing. They can occasionally crop up in young adults where they may be confused for embryonal tumors. They have very finely fibrillar cellular processes. It looks similar to neuropil. High NC ratios are frequently negative for glial immunohistochemical markers. Here's an example of OLIG2 and GFAP. In this instance, GFAP is hitting some background infiltrated brain. And then positivity for neuronal markers is much more common, such as synaptophysin, and occasionally other neuronal or neuroepithelial markers can be positive. And these tumors frequently show ATRX and P53 mutant patterns as well. So if that's part of your panel, be aware. And for these, usually sequencing is required. Some centers do have histone G34 mutant specific IHC. If that is something that you have access to, it's highly recommended. It will certainly save you some money and time when it comes to profiling these tumors. But here's just an example of the copy number plot, which just shows pure chaos and isn't terribly diagnostic in and of itself. So if one is running an assay that has this information generated, one can see that kind of profile. By contrast, the diffuse midline gliomas, just as the name suggests, are gliomas that are diffusely infiltrative through midline structures. They can occur, cerebellum, brainstem, deep nuclei, and can really have a variety of histologic appearances. They're usually high-grade astrocytomas. One would not be terribly confused in most instances as to the grade or nature of these tumors, but occasional tumors that used to be referred to as diffuse intrinsic pontine gliomas, those that are diffusely expansile within the pons, can show lower grade histology. And it's worth noting that those are often histone driven as well. And irrespective of the histologic appearance, all of these tumors are grade 4. And these arise by a lysine 27 or 28 mutation, depending on your how your nomenclature is issued to methionine trans missense mutation. This can be picked up with mutation-specific immunohistochemistry. That's what's being shown in each of these panels down here. Here's another example. So if one is running IDH, it might be helpful because many of these have ATRX loss. In our practice, we tend to see many of those that arise in the thalamus in older individuals, and those can have almost an oligo-like appearance. Many of these tumors have perinuclear clearing and this kind of delicate branching vasculature as well. So if you have a tumor that is similar to an oligo in the thalamus or basal ganglia, please think of this entity. IDH will be negative. The ATRX will be lost, and if one has the K27M mutation-specific antibody, it'll show nice nuclear positivity in those tumor cells. The result of this mutation is a loss of trimethylation at this very same residue. So if your lab has the trimethylation marker for H3K27, that's something that can be used as an adjunct, and it will show loss of expression. So that can be very helpful in many instances. If this antibody is not present or doesn't work, it can be fairly finicky in some labs. And then of course, just note that these histone tumors, as we saw with the G34 mutant tumor, can be bimutant for both ATRX and P53. So you may also want to throw an IDH stain on there just to make sure that that's not what we're dealing with. So that's the end of my material. I will stop my screen share now and let Dr. Santagata take over.
Hi, everyone. Really nice to have the opportunity to speak with you. And I really enjoyed Dr. Meredith's presentation. So I'll continue speaking about non-glial brain tumors, since Dr. Meredith did such an amazing job covering both pediatric and adult glial tumors. What I'm aiming to do is to talk about a few different types of tumors in some depth. Meningiomas, Craniopharyngiomas, and other tumors of the cellular region will probably be the large majority of what I'll speak about, and some cystic lesions. Starting with meningiomas, they're this is a plot of the frequency. They're the most common primary intracranial tumor. They're pretty rare in children, but they're very common in adults with a median age around 64 or 65 years of age. In the younger population, they're more common in females than in males, roughly 2.3, 2.4 to 1. So it's pretty skewed towards females, but higher grade tumors, atypicals and anaplastics, occur with equal frequency in men and women. We break them down by grade. A large majority of these are grade 1. Smaller fraction, about a quarter, 20% are higher grade. And then most of them are single tumors, but many of them, meaning roughly like 10%, can be multifocal. So in terms of risk factors for these tumors, being female is the highest risk factor, but so is ionizing radiation, generally experienced during childhood. Elevated body mass index, high BMI, is associated with increased risk of meningiomas, and then familial predisposition syndromes, NF2 being the classic one, and I'll speak about several of them in subsequent slides. This is a view of an autopsy brain showing arachnoid granulations here in the midline, higher power view, and then the histologic view showing those arachnoid cap cells. So meningiomas reflect an expansion of this this morphology of cells. One of the caveats is that you can see meningothelial hyperplasia around other tumors. So in these two examples, this is an optic nerve glioma, and there's a proliferation of meningothelial cells around that glioma. And here at present near a paraspinal neurofibroma is also meningothelial hyperplasia to be discriminated from actually neoplastic cells. The other classic characteristic of meningiomas in terms of the radiology is the dural tail, as you can see here. And when those are examined histologically, occasionally you will find meningioma cells and sometimes just reactive fibrovascular tissue. So it's a combination of these two types of findings in that dural tail. Meningioma cells can infiltrate into the bone. They can invade the bone into the intratrabecular spaces and lead to a hyperostotic reaction, which can lead to an expansion of portions of the cranium. And here you can see the meningothelial tumor cells in the intratrabecular spaces. Classic histologic findings of these tumors are noted on these slides. So pseudo inclusions, where they're pseudo because they're not real inclusions. They're just holes due to invagination of the cytoplasm into the nucleus. Tight whorls in this transitional meningioma, and I'll get into the subtypes shortly. These tight whorls are another classic feature, as are psammoma bodies, and here in a psammomatous meningioma, they're very, very prominent, and I'll show you some of that in a bit. As Dr. Meredith had shown, glial tumors on a cytologic preparation, on a smear prep, have these long fibrillary interlacing processes, whereas meningioma cells, they're kind of flat, broad, and then they kind of abruptly end. So they're not long and fibrillary, just as a point to discriminate these on a smear prep in the frozen section room. We have a number of types, roughly 15 types of meningiomas, sometimes more, depending on how they're looked upon, that all fit under this umbrella of meningioma. The most basic types are in the next few slides, which are meningothelial. This is shown here. We have these epithelioid cells. They have a syncytial-like appearance. They do have cell boundaries, but they don't look to have those on H&E. And these are the ones that most closely resemble the arachnoid cap cells, and they're these thin septa here, fibrovascular septa that are present. Fibroblastic meningiomas are quite different. They're spindle cells. They're parallel bundles and storiform patterns, and they can be collagen rich, sometimes so rich that you need to discriminate them from a solitary fibrous tumor. In that case, STAT6 immunohistochemistry can be very useful. Both of these types generally are grade 1, and I'll get into some of the grading issues and complexities of that, which is increasingly an area of investigation and revision of our guidelines. Additional subtypes are the transitional, which is an intermixture of the meningothelial and the fibrous and some transition states. As you can see here, lots of whorls are present in these, and these tend to have quite a few psammoma bodies as well, although not depicted in this image. And then the other side are the psammomatous meningiomas with lots and lots of psammoma bodies, sometimes so dense that they form a big aggregated mass. These tend to be found in the thoracic spine of middle-aged to elderly women, and these also are grade 1 tumors. The other histotypes that are a little more uncommon, angiomatous, as seen here, this dense network of vascular spaces doesn't even look much like the other meningiomas that we looked at. They tend to have hyalinized vessels. They can co-occur. This pattern can co-occur with the microcystic pattern. They're molecularly related, hence the co-occurrence, and they're part of a kind of a histological spectrum. These have like a cobweb-like microcystic pattern. You'll also typically see some large cells, even larger than what we're showing here, that are called degenerative atypia. And here's a good example here of a cell. That doesn't mean that they're more malignant. They're just these degenerative atypical cells. And these are frequently associated with edema, as is the secretory type, which is in the next slide. So these are additionally they're meningiomas, and I'll get into some of the molecular definitions of these as well in a bit. They form these foci of gland-like structures that kind of have epithelial differentiation. They express carcinoembryonic antigen, keratin, and these also tend to be PAS positive. And again, these also cause edema is the classic teaching. Also WHO grade 1. And then as we get towards the end of the WHO01 tumors, are the very uncommon ones, the lymphoplasmacyte rich, which tend to have lymphocytes and macrophages and not so many plasma cells typically. And it can often be very difficult to identify the tumor, sometimes to the point where you wonder whether it's meningothelial hyperplasia relative to an inflammatory disorder. And then the metaplastic meningiomas can have adipose tissue type differentiations, xanthomatous change, cartilage, mesenchymal components, etc., but also rather uncommon meningioma type to find. Then as we move into the grade 2 classes of meningiomas, we have choroid meningioma here on the left and clear cell on the right. Choroid meningiomas, they resemble chordomas. They have these cords of trabecula. They look kind of a little bit epithelioid, sometimes spindled, and lots of vacuolated mucin-rich cytoplasm. And whereas the clear cell meningiomas, they're pretty patternless. They tend to have polygonal cells, tend to have a cleared out cytoplasm, but a key feature is also the very dense interstitial collagen, which is characteristic of these tumors and shown here by these big bundles here. The teaching with these is that they're WHO grade 2, therefore they have a higher risk of recurrence. So it's important to note that these, to note these morphologies, and they tend to, the borderline for calling a tumor one of these tends to be at least 50% of the morphology needs to look like this. And there are also molecular features that I'll describe shortly for clear cell that help with the diagnosis. Here's another image of choroid meningioma shown in Alcium blue, highlighting the extracellular matrix, really pretty stain that also assists a little bit with the diagnosis of this WHO grade 2 tumor. And here's another view of the clear cell meningioma showing a trichrome, using a trichrome stain to highlight the collagen and a PAS to highlight the intracytoplasmic glycogen that accumulates in these tumors. The other very distinctive subtype of meningiomas are the rhabdoid meningiomas. These are traditionally called WHO grade 3, and I'll give you some caveats related to that in a second. These are pretty plump cells. This is a really good example with tend to have large nucleoli and these very prominent eosinophilic paranuclear inclusions that can push the nucleus off to the side. So that's one of the really distinctive features of these tumors. And I mentioned the caveat about grading. A report by Caterina Giannini's group at the Mayo Clinic showed that rhabdoid features can be found in tumors that do not have any other high-grade features. And the conclusion from this paper is that these should be graded according to the more traditional grading guidelines of meningiomas in terms of the mitotic count and other atypical features, so that in principle one could have a rhabdoid meningioma that would be a grade 2, for instance, as opposed to a grade 3 based upon the grading criteria. And I'll show an example of the grading criteria in a bit. So that's a bit of a more nuanced change that's been occurring in the field in terms of grading. And the same applies for papillary meningiomas, which are also traditionally grade 3. These are, this is actually a papillary rhabdoid meningioma where the rhabdoid cells are forming a papillary pattern. So it's not uncommon when you see these rare tumors that they will both occur together like this. In terms of meningioma markers, traditionally we've used epithelial membrane antigen, EMA, but more recently, last 5 years or so, a little longer now, we've been using somatostatin receptor 2A, which provides a slightly more sensitive diagnostic marker. Often they can be used together to help in cases that it's not clear that it's a meningioma, perhaps some of those microcystic cases or angiomatous cases where the meningioma cells are not easily seen. So this is a slide from one of my neurosurgeon colleagues, Linda B., which is a collection of meningioma patients that she's worked on and resected. And you can see there's a wide variety of different radiological features that are present in these tumors. And for instance, what's interesting about this particular series of patients, these different patients, is that they look quite different from each other, and they actually look rather aggressive. It doesn't look like a benign pattern, but the histology of these, and this is why Linda put this slide together, is that they're grade 1 meningiomas on histology. So higher grade appearance by radiology, but low grade appearance by histology. So it's kind of this wolf and sheep in wolf clothing idea, where they may look benign but act aggressively, and we sort of need additional markers to tell us, molecular markers, as David was showing, for a wide variety of gliomas. The same is true for meningiomas, and the field is catching up in terms of providing some of that information to help us identify more aggressive meningioma behavior. So our traditional grading scheme is indicated on the left here, where we look at a range of features, and I'll show some examples of these shortly, but whether the tumor cells are sheeting, whether they're small cells, et cetera, we count those up. And if there are 3 or more of these aggressive features, the tumor is called, is labeled and designated as a WHO grade 2 tumor. The other way that a tumor can get designated WHO grade 2 is to see 4 mitoses or more per 10 high power field, but less than 20, which meets the criteria for a WHO grade 3 anaplastic meningioma. So these are the difference between a grade 2 atypical and a grade 3 anaplastic. The other key feature, and this is remains controversial, and I'll try to explain why in a second, but you can have tumors that have invasion into the brain, and that's defined by seeing a rim of brain tissue around the invasive portion of the tumor. I highlighted it here in green because, you know, it can be rather challenging to find whether it's invasive or not, and that leads to sort of some discrepancy, I think, in terms of whether these should be called grade 2 or grade 1. But traditionally, if one sees by our guidelines now, if one sees brain invasion, these are labeled as WHO grade 2 tumors, indicating an increased risk of recurrence. So grading criteria, as I mentioned, the number of mitoses, 4 per 10 high power fields, or 20 per 10 is for the anaplastic category, and just noting that the fields are of a defined area indicated by millimeters squared. So grading criteria by histology, those 3 atypical features. This is an example of a sheeting type pattern where there's loss of that whirling architecture and more of a kind of a continuous stream of tumor cells. Another feature is high nuclear to cytoplasmic ratio, or small cell change. The pink cytoplasm here is lost, and you see a piling up of these small blue cells. So it can be a little complicated when this is only very focal, but generally when one sees a fair amount of this pattern, that is a feature that leads to an atypical grading. Here is an example of prominent nucleoli. These tend to be seen when one can see them at 100x using a 10x objective. This is generally when kind of the visual threshold for calling prominent nucleoli, and then the presence of spontaneous necrosis that's not induced by embolization. Then we have the issue of frank anaplasia, where the tumors just look highly aggressive. Either they look like a carcinoma, or they have the appearance of a fibrosarcoma, and this is then sufficient for a WHO grade 3 designation. So what are some of these molecular markers that can be used to help us figure out which meningiomas will be more aggressive? So one of them that's been proposed is an immunohistochemical stain for trimethylation, ME3, trimethylation of histone 3 at lysine 27, so H3K27 trimethyl, or ME3. This, when this signal is lost, and when it's retained in the blood vessels but lost in the tumor cells, here you can see these not like bar bodies, but that's lost because the nuclei are negative. When this is lost in grade 2 meningiomas, that tends to be an indicator of an increased risk of recurrence. Meta-analyses tend to show this is a little bit less, or hazard ratio of a little bit less than 2, resulting from loss of H3K27 trimethyl. This is found to be lost in 3% of grade 1s, 10% of grade 2s, and roughly 20% of grade 3s, but it's most diagnostically useful in terms of discriminating aggressive versus non-aggressive meningiomas in the grade 2 category. The other feature, as in gliomas, homozygous, and then also we tend to believe also heterozygous loss of CDKN2A protein, genetic locus, on chromosome 9p, is strongly related with poor prognosis, whether it's in grade 2 meningiomas. Here's is the progression-free survival of patients with CDKN2A deletion versus non-deleted, and in grade 3s as well. So even though these are high-grade anaplastic, they can still be discriminated in terms of their aggressive behavior, whether the tumor has a deletion or no deletion of CDKN2A. The other molecular feature that's important that can be identified by sequencing is our TERT promoter mutation. So 2 canonical mutations that can occur in the TERT promoter, and across all grades and within grades, loss of TERT promoter mutation is associated with very bad outcomes. So TERT mutant versus non-mutant, you can see a rather dramatic difference in progression-free survival. So this is an assay where it's sequencing-based assay. The detection of CDKN2A can be done either by a copy number array or also by FISH, which is a little more pragmatic in some instances. So a few different ways of getting at this molecular information. We in our center have been looking at copy number of meningiomas for quite a while, and here's kind of a representation of the features that are typically seen in terms of copy numbers, which for meningiomas in grade 1 meningiomas, they tend to have monosomy 22, loss of chromosome 22 indicated here in blue, whereas higher grade meningiomas tend to lose a number of different chromosomes, chromosome 1p, chromosome 6q or monosomy of chromosome 6, 9p in as well, that where CDKN2A resides, chromosome 10, and et cetera, and a few additional ones as well. And then there's some gains, and I'll mention the value of those as well. And if you look at this cohort of nearly a little over 1,000 meningiomas, and we stratify them by their molecular by their histologic grade, it's actually kind of interesting because you start to see there are a number of meningiomas that don't have any copy number changes in grade 1, which is what we expected. They're lower grade. They haven't started to scramble their genomes. Then there are ones that have gains of a number of chromosomes, and these tend to be the angiomatous microcystic meningiomas, still grade 1, even though they have copy number changes. But then oddly enough, there are a number that have quite a few losses, including of 1p. So these, we believe, and I'll show you some data in a second, that these are going to be higher grade meningiomas, even though histologically we find them to be grade 1. We would in our center suggest that these might have higher risk of recurrence and therefore warrant closer follow-up. Conversely, in the grade 2 category, there are meningiomas that have quiet genomes. And we believe that these, also supported by data, that they are less likely to recur. So they're almost going to behave like these grade 1s, even though they were classified as grade 2 on histology. However, a large fraction of grade 2s indeed have copy number changes consistent with grade 2s, and therefore this is supporting a grade 2 diagnosis both histologically and molecularly. And grade 3 tumors tend to have a whole range of changes, including deletion of CDKN2A on 9p, which is shown here. So these are the features that the molecular features that we think are associated with increased recurrence, most notably CDKN2A deletion, but also loss of chromosome 1p and several others. So you can look at those in this manuscript from last year, but it's helpful to have a wide range of different features. We've developed what we call an integrated grade, where we give 1 point for the presence of each of these chromosomal abnormalities, also 1 point for the presence of mitoses, and 2 points for presence of over 20 mitoses. So this is 4 to 19 so 1 point, over 20 gets 2 points. We then add these up and then provide what we call an integrated grade. So grade 1s are 0 to 1 of these events. So for instance, if a tumor has 4 mitoses but no other change, this would still be a grade 1 because there were no molecular changes associated with higher grade. Grade 2s have 2 or 3 points, and grade 3s for us have 4 or more points. Pretty straightforward, reproducible system for doing so. And when we do this, we can start to see a reorienting, repositioning, reassignment of histologic grade into molecular grade. So some histologic grade 1s become grade 2s. Some grade 2s, about a third of them of the grade 2s become grade 1s versus staying grade 2s versus moving to grade 3s. So there's a reassignment based upon integrated grade, which we think is interesting. And then there's this middle category of meningiomas with atypical features, where they didn't quite make it to grade 2 based upon the presence of atypical features, maybe 1, maybe 2, but not 3. Many of those remain grade 1, but a few of those are reassigned to grade 2 or higher. And why do we think this is interesting? Well, if we take our WHO grade 2 and 3 histologic, assigned by histology meningiomas, but the ones that had this histologic assignment but were molecularly a grade 1, those patients actually do really, really well. The tumors don't tend to recur. Whereas meningiomas that were histologically grade 1 but had higher grade chromosomal features, or at least higher grade integrated grade features, those do tend to recur. And then getting to the point of brain invasion, we think this type of assignment and this type of molecular assessment is useful in brain invasive meningiomas, because the brain invasive meningiomas that have integrated grade 1, basically lower grade molecular features, those brain invasive meningiomas those patients tend to do well, whereas patients with brain invasive meningiomas that are integrated grade 2 or 3, they tend to recur. So we think we can stratify these tumors based upon molecular criteria. The key feature, though, for surgeons out there is that surgical resection still matters, whether the meningioma is grade 1 or grade 2. A subtotal resection is associated with increased risk of recurrence, regardless of the integrated grade of the meningioma. A few last points on meningioma. The histologies are tightly linked with genetic aberrations, so, and also location, which I'll show in the next slide. So these meningothelial meningiomas, which tend to occur in the anterior skull base, tend to have a certain profile with smoothing mutations and AKT mutations and PI3 kinase mutations. NF2 mutation mutant meningiomas, the fibroblastic ones, tend to occur, well, the fibroblastic ones tend to have NF2 mutations, and they tend to occur in the convexities. Angiomatous meningiomas tend to have chromosomal polysomies. Secretory meningiomas almost invariably have KLF4 and TRAF7 mutations, tend to occur in the skull base. Clear cell meningiomas, all of them tend to have, the vast majority tend to have SMARC-E1 mutations. So this is, what's interesting about this is this can be tested for by immunohistochemistry. So it's not necessary to do genetic sequencing to identify these and support the diagnosis. These largely are spinal meningiomas, but can also occur in the posterior fossa and the convexities as well, but largely spinal meningiomas and part of a genetic predisposition syndrome. And BAP1, it tends to be lost in rhabdoid meningiomas, although not all of the rhabdoid meningiomas, a subset of those. Another point to mention is that meningiomas can arise as part of tumor predisposition syndromes. I mentioned at the beginning that they arise in patients that have NF2. Those patients will have bilateral schwannomas, and they can have multiple meningiomas and spinal ependymomas. SMARC-E1 germline mutations can lead to clear cell meningiomas, typically of the spinal cord. SMARC-B1, LTZR1 mutations can be found in patients that have multiple schwannomas and also multiple meningiomas. These patients have a lesion in one of these, and then they pick up an NF2 mutation and activation as well, and that leads to the formation of these tumors. Germline BAP1 mutations are important because when one finds a rhabdoid meningioma, if it indeed has loss of BAP1, that could either arise by somatic mutations or by a germline mutation followed by a somatic second hit. These patients tend to have other BAP1 related tumors. So the families can have uveal melanoma, cutaneous melanoma, mesothelioma, renal cell carcinoma, cholangiocarcinoma, and have very classic atypical Spitz tumors. Similar to SMARC-E1, BAP1 loss can be identified by immunohistochemistry, preservation in the vasculature and stromal cells, loss in the tumor cells. So if a BAP1 meningioma is found, it's useful to look at family history to see if this could be a germline mutation. And then the final points with the meningioma is that, again, location, mutation, and histology are very tightly linked. So certain mutations will occur in certain tumors in certain locations in the brain. So smoothing, for instance, is very common in the olfactory groove meningiomas. NF2 is very common in the convexity meningiomas, which then often tend to have chromosomal instability and tend to go on to be higher grade. And then this is just a summary of that, but it's no need to go too much into detail of these molecular patterns. So pivoting to craniopharyngiomas, so these are neoplastic cystic lesions in the cellular suprasellar region. There are two main types. There's the adamantinomatous type of craniopharyngioma that arises both in children and in adults, whereas the papillary type of meningioma occurs almost exclusively, not exclusively, there are rare cases, but almost exclusively in adults. These tumors have very classic histomorphology. There's well-differentiated squamous epithelium that occurs in these sort of lobules, cords, and whorls. There's peripheral palisading of the columnar epithelium. There's this loosely knit stellate reticulum, very classic here, you can see here, and also wet keratin, which are these ghost-like anucleated cells. So very, very classic morphology. Malignant transformation does occur, but it's extraordinarily rare. It happens frequently many years after radiation for a lower grade, looking at a standard craniopharyngioma, and these then tend to develop P53 mutations. And here's an example of the histology of those. So you go from these very benign looking tumors to these rather aggressive looking tumors with many mitoses, sheet-like growth, and necrosis. Extremely uncommon, but to be aware that these type of tumors can arise in the setting of a prior lower grade adamantinomatous craniopharyngioma. The other subtype is the papillary craniopharyngioma, named because these tend to have a papillary appearance. Like adamantinomatous, they can also have cyst-like structures, a little bit less common. Adamantinomatous tend to have larger cysts. Papillary tend to be a little bit more solid and also tend to be a little bit further up in the suprasellar region, sort of towards the third ventricle. In terms of the histology, there's these epithelial sheets and these fibrovascular cores, and I'll show you a slide of that in a second, just to show you that there's a lot of comorbidity associated with these tumors. This is an image of a young girl who had a craniopharyngioma. Post-resection, the tumor plus the surgery can lead to a lot of endocrine sequelae, delayed growth and puberty, hypothalamic disturbances that can lead to morbid obesity and other problems, troubles with vascular problems, moya, impaired intellectual problems, hypothalamic dysfunction, panhypopituitarism. There's really a really low-grade tumor in terms of histology, but very dramatic effects on people's lives. Pivoting back to the histology of papillary craniopharyngioma, you have these compact monomorphic sheets of well-differentiated squamous epithelium, but unlike the adamantinomatous craniopharyngiomas, these are without keratinization. They don't have calcifications. They're infrequently, you'll find ciliated cells that are PAS positive goblet cells. And also another very distinctive feature are these tumor infiltrating neutrophils. So it's very common even on a small piece of tissue to be able to find many, sometimes rather brisk tumor infiltrating neutrophils. But then in the fibrovascular core, it's kind of a very hypocellular environment, a few lymphocytes, scattered fibroblasts, a few macrophages, but very hypocellular. The tumors can be defined by very distinctive molecular features. So adamantinomatous craniopharyngiomas are nearly all of them have beta-catenin mutations in exon 3 of the beta-catenin gene, CTNNB1, whereas papillary craniopharyngiomas, almost all of those have BRAF mutations, the V600E, that's classic of lower grade gliomas, but also of melanoma. What's interesting in terms of molecular surrogates, David showed you a number of those by immunohistochemistry. There are a few that are applicable here as well. So immunohistochemistry for beta-catenin itself is useful for the adamantinomatous craniopharyngioma. And what's kind of interesting, even though not necessarily diagnostically, what's interesting is that the protein accumulates in the nuclei of cells, but only a subset of them. So even though this is all neoplastic tumor epithelium, the protein will only go to the nucleus, translocate to the nucleus in these whorls, largely these kind of whorl-like structures that are common in adamantinomatous craniopharyngioma and a few scattered cells. Here in this example, there's a little bit more widespread nuclear translocation, but in comparison to the papillary craniopharyngioma, where beta-catenin remains in the membrane, here it's very clearly in the nucleus, which is useful. The flip side is that for papillary craniopharyngiomas, instead of doing genetic sequencing, one can use immunohistochemistry using an antibody that recognizes the mutant form of BRAF. So the BRAF wild type with the valine at position 600 is not recognized, but when that's valine is replaced by codons that lead to a glutamate, you can now get very I would say very okay staining, kind of a light staining pattern, but very clearly positive staining that sometimes needs to be confirmed by sequencing. But that's another example of a surrogate. One of the challenges that can arise is in the differential diagnosis of other tumors that arise in this area. One of these is a Raschke's cleft cyst, so not a tumor, but an expansion, maybe a tumor in the classic sense of a mass. These cystic masses have ciliated mucus-producing epithelium and scattered goblet cells. So very clear, when it's this classic, it's very easy to identify this as a Raschke's cleft cyst and not a papillary craniopharyngioma or adamantinomatous craniopharyngioma. Gets a little bit more complicated when there's cyst rupture and xanthogranulomatous changes with these cholesterol clefts, fibrosis, hemosiderin, and multinucleated giant cells floating around in here. So it's in those cases, it requires a hunt for some of the neoplastic epithelium or the strips of cyst lining as well. Sometimes immunohistochemistry can help in those settings. What we do see sometimes is that there are Rathke's cleft cysts, though, with very prominent squamous metaplasia, and then these start to look a little bit like papillary craniopharyngiomas. So studies have shown in these cases that antibody staining for V600E can be helpful in discriminating squamous metaplasia, which should be negative for a mutation versus a papillary cranial that will be positive for the mutation. Here's an example of positive staining again. One caveat is that in Rathke's cleft cysts, this same antibody that recognizes the BRAF mutant protein also recognizes proteins in cilia. So it recognizes proteins actually in flagella, cilia through the body. So it's just a caveat that there's cross reaction with proteins in the cilia arms. So it's important to be aware of that caveat. What's pretty neat is that these tumors tend to be highly responsive to therapy. So, and now I'm speaking specifically about papillary craniopharyngioma. So this is an example of a patient that received a BRAF inhibitor and a MEK inhibitor. After 2 weeks, there was about a 50% reduction in the volume of the tumor. After just a month, the tumor was reduced by 85+%. So a pretty exciting example of targeted therapy. This is the post resection of that craniopharyngioma, showing a really big influx of these foamy macrophages. Also, immunohistochemistry shows that there are lots of T cells. So there's a really strong immune response after the targeted therapy that targets the BRAF mutation in this neoplastic epithelium. And there's also very dense fibrovascular scarring that occurs too. So these tumors tend to shrink down. Based on this, a clinical trial was recently performed over the last actually 5 years, which split papillary craniopharyngioma patients into 2 cohorts: cohort A, which are newly diagnosed craniopharyngioma, and cohort B, which are recurrent craniopharyngiomas. These patients were treated with combination therapy, BRAF MEK inhibition, and this is an example of the responses for 16 patients that were treated. Every patient that received more than 1 cycle had a very dramatic response. This is the tumor volume after 4 cycles of therapy. The median reduction was 91%. This one patient that had no response stopped therapy before completing the first cycle because of negative reaction and adverse event to the medication. So pretty dramatic responses. So a good example of targeted therapy in brain tumors. There's some other masses that can come into differential of skull-based lesions and other lesions in this area. Neuroenteric cysts can occur even though they're largely spinal. We can see these cyst structures in the brainstem, pretty uncommon. They're either called enterogenous or endodermal, or bronchogenic, or foregut cysts. They can have pseudostratified columnar epithelium with ciliated cells, including goblet cells. Other cysts that are common in the brain are epidermoid cysts, which can occur in the cerebropontine angle. These have simple stratified squamous epithelium. They do not have adnexal structures, and they have large amounts of keratinaceous debris, which can be more and more prominent on recurrence of these cysts, which, even though they're cysts, they can be kind of difficult to treat. And then the counterpart of these are dermoid cysts, which instead of occurring in this CPA angle, these tend to occur more often in the midline. These have mature epidermis, but they also have adnexal structures, so sebaceous glands, and then they also can rupture. And here you can see a little bit of a fragment of hair in this cyst structure. And then the other type of cyst that's common to see more often in the pediatric population are arachnoid cysts. These have very, very thin epithelial or arachnoidal lining. It can be difficult to see and often highlighted best by immunohistochemistry stains such as EMA. Now, pivoting a little bit towards the other tumors that can arise in the sellar region. These are more in the sella themselves, and I'll start sort of in the infundibulum and the neurohypophysis here, and then move forward to the adenohypophysis. But this is an example of a granular cell tumor of the infundibulum. They can occur in the stalk itself. They can occur in anywhere along basically the stalk through the posterior pit. And here's an example of the granular pattern, a little bit higher power, so that they have this granular pattern that's associated with lysosomal accumulation. These tend to be PS diastase resistant. And interestingly, they show TTF1 positivity. So TTF1 is a very useful marker for identifying these tumors, as are other markers like S100 and alpha-1 antitrypsin as well. There are three types of tumors mainly that occur in the posterior pituitary. These are, as I mentioned, the granule cell tumor of the neurohypophysis, but also pituocytomas and spindle cell oncocytomas. These two, pituocytomas and spindle cell oncocytomas, tend to occur along a morphological gradient. It can be useful to try to discriminate them because spindle cell oncocytomas tend to have a slightly increased risk of recurrence. These can be identified by anti-mitochondrial antibodies. PAS stains can also be useful to some degree in discriminating these different tumor types. But the unifying feature and why they're part of a continuum is that they are thought to arise from pituocytes or pituocyte, so does it demonstrate pituocyte lineage, and those are cells in the posterior pituitary that are positive for the TTF1 transcription factor, which, as we know, is very common in thyroid lesions, but also commonly used in pulmonary lung carcinoma pathology diagnostics. Pivoting towards the front of the pituitary, this is just an example of a pattern of normal pituitary with a really pretty staining for reticulin, which shows the nested pattern of growth or of architecture, a spatial organization of the normal anterior pituitary. And instead of going into all the vast possibilities for what can occur, the tumors that can arise in the pituitary, which will be several hours of discussion amongst us. I'm just going to show you just this one, I think, very interesting key development over the last 5 to 10 years in the field is the use of lineage transcription factors in the diagnosis of null cell adenomas. So these are adenomas that, after a complete workup, identification of this typical monomorphic pattern of histology, which you can see in these H&E snippets over here. After looking for pituitary hormone production, if none is found, one can then take these quote unquote null cell adenomas and try to do lineage assignments based upon the expression of certain transcription factors. So even though they don't make luteinizing hormone or follicle stimulating hormone or ACTH or growth hormone, prolactin, et cetera, they can be identified by these transcription factors. So the presence of SF1 nuclear staining is indicative of a silent gonadotrope. These are the most common, roughly half, maybe slightly more, of null cell adenomas fit into this category, can be reassigned to this category. About a third are T-PIT positive, so they'll be negative for SF1. These tumors, they'll be negative for SF1 and they'll be negative for PIT1, but they're positive for TPIT. That's indicative of a silent corticotroph. And then lastly, a very small percentage, only a few, 1, 2, 3, 4% of null cell adenomas will stain positive for PIT1, indicating more of a growth hormone prolactin type phenotype. And the other point that's important in pituitaries that's changed over the last decade as well. When I started training, we would look for mitoses, and we still do, but we would use them to identify what are mitoses plus P53 staining to identify atypical adenomas. We no longer do that as commonly, more commonly now. In addition to before, we'd also do a Ki67 and have like a 2 to 3% threshold. More commonly now, aggressive behavior is specified as being linked to certain morphologies. Certain types of pituitary adenomas, and those types are listed here. Just a couple of maybe atypical examples of lesions, pituitary adenoma type lesions. This one here is an example from a 14-year-old boy who had a lesion that was grown into the left cavernous sinus. So it was not, there was no cellular connection here. It looked like it had pituitary adenoma histology. The tumor actually had ACTH expression. It was synaptophysin positive. It stained for TPIT as well. So this is an ectopic ACTH producing pituitary adenoma, pretty uncommon, but not unheard of. And ectopic adenomas tend to have ACTH production. Another pretty unusual morphology is this mixed gangliocytoma adenoma. And in this case, one can see pituitary adenoma, but the presence of these gangliocytoma cells, which can either be present around the monomorphic cells are in more differentiated neuroglial tissue. Here again, the lineage transcription factors are helpful. T-PIT staining was identified in this and actually this should be listed as PIT1 staining was identified here, and HGH staining was also seen. So in closing, I think what's really exciting to me about what Dr. Meredith showed and what I showed you and what our field together as pathologists we're doing all throughout different tumors, whether it's in the brain or whether it's peripheral, and maybe this is a good way to end this webinar series for the year, is that we're bringing new tools to bear on our tumor tissues, trying to extract more information and trying to learn more about them to better help our patients in terms of stratifying the tumors, identifying targets, BRAF mutations, for instance, and other targets, IDH mutations, which now low-grade gliomas with IDH mutations are shown to be responsive to IDH inhibition. So a lot of exciting developments, but there's obviously more and more to do. I kind of have like my worldview of our field, at least what I view we'll be doing over the next years in terms of new technologies. This is in this H10 video. It's an hour-long lecture, so I'll spare you the full hour's worth of material, but you might want to have a look at this, because I think our field is really undergoing a transformation from using genetic tools very effectively to now adding on additional tools for spatial imaging. And I think what we're going to do in the brain and elsewhere in the body is to take all this 100 years of information that we've accumulated as a field all around the world, these really amazing pathologists that have come before us in terms of the information they've gleaned from H&E and also by using immunohistochemistry, which has really only been around, roughly 40 years. So you can still talk to pathologists that were around when these tools were being first implemented and the challenges they had and how they struggle with figuring out how to use antigen retrieval. So the stuff we take for granted today was, it's only one generation of pathologists ago when those were implemented, but there's 100 years plus of information about morphology and key disease relevant morphologies and molecular information that we've gleaned that we can now put to bear on our patients. But now we have these pretty remarkable, amazing tools. And this is what I spend most of my day doing. So I'll tell you maybe like the last 5 minutes of some of the stuff that I see our field going off and doing. We obviously have really interesting digital pathology tools with mass spectrometry imaging. We can measure metabolites effectively across tissues spatially. We can bring RNA tools as well, where we look at transcriptional profiles, but spatially assigned. So you can monitor 100, 200, up to several thousand genes now and spatially assign those into to specific cells. And then the work that we do is we take antibodies, same as with IHC, but now we multiplex them. So instead of putting one on a slide, we'll put 20, 30, 40 plus antibodies onto a slide and image that slide, and then do molecular assignments of the cells based upon that multiplexed imaging, increasingly in 3 dimensions, which is really kind of fun and interesting. Both narrowed thin section 3 dimensions. Here you can see a macrophage with a long arm inhibiting a T cell in the distance, as well as thick section 3D, start to see interconnected structures, which are pretty neat. When we get this data, and I think this is an appealing concept for everyone, is this, we do this routinely, but basic scientists don't really understand how we do this until they come visit us or see a picture like this with these kind of really ridiculous looking microscopes when you think about it, right? So we have this didactic approach where we train each other, which is really a remarkable way to teach each other, where there's someone at the head of the microscope and teaching the trainees about information. But when this goes to a manuscript, we get these little postage stamp, either H&E images, IHC images, or increasingly multiplex images, which are kind of frustrating. So we think there needs to be data liberation. So what we're trying to do is to push out these tools to the scientific community in an attempt to share images. And this is inspired by what we do at the microscope, but also inspired what we see in museums. This is an image of a Salvador Dali painting, but you need to follow your tour guide with the flag. So we can do the same thing for images now using digital tools. So this is an example not of H&E, although we have H&E examples of this. Anyone can pull up an image that they have, a scanned image put this into this viewer, and then develop their own guided tour for the images. We think this might be ultimately useful for training, for education, for the WHO, for instance, et cetera. So what's neat about this is you can develop a story around an image and walk someone through your story. So here, for instance, it's a lung cancer story, lung 3. You can listen to the audio or just read their different table of contents. These are what are called the waypoints. Click on the arrow and you move forward. So let me see if I can move this forward. I hope, yeah, here we go. So this will move forward. So this is a guided tour through the sample of someone showing macrophages and then inhibitory T cells and rare immune populations, et cetera, et cetera. So we have this ability to start to share data, and then anyone can disengage from this, pan around, zoom around, find the areas that they're interested in, click around to see the different marker combinations they'd like. So there's a lot that one can do, either in display in H&E, but also display in IHC, and also display in multiplex tools, multiplex data to people. And we're trying to embed some of these tools in the commonly used CBio portal for genomics. So now people can link genomic information with histomorphologic information. The last couple of slides is what I'm even more excited about recently is that we've been able to merge some of this antibody staining with what we do as pathologists on H&E. So this is same section. We can apply 16 antibodies to a single section. We can measure their intensities, separate the signals from one another, measure intrinsic autofluorescence, and then do an H&E on that same section, and then digitally integrate it. So you can say, you can see, oh yeah, those are lymphocytes, and they're CD45 staining. They're macrophages somewhere in here, and stain them with CD68 and fibroblast markers, et cetera, et cetera. And then this is a data overlay. And what's cool to me, and this is that Minerva viewer, but now we have this thing called a lensing tool, and this is the last slide. But what we can do with now is you can sort of probe around and visit this integrated H&E and IF image. And to me, it's kind of neat because you can take the lens and then use this crossfading tool and kind of dial down the H&E and dial up the immunofluorescence. Looking at here in blue is CD45 positive cells, and green is cytokeratins of the tumor cells. And you can dial up or dial back down and then pan around. And if you go to tissueatlas.org or our GitHub page, you can start to see these are colorectal cancer specimens. And increasingly, we're going to put more and more of this type of data out there so that we can build molecular classifiers that take into account our morphologic features, which we're very comfortable with additional molecular information. Anyhow, I just want to thank you for listening to Dr. Meredith and myself talk about brain tumors, give you a little glimpse of a bit of the future. Also credit to diagnostic pathology and neuropathology, where some of these images were taken. So thank you very much. And I think both Dr. Meredith and I will take any questions you may have, either I think in the chat, or I think you can unmute as well, either way. That's a really nice comment. Thank you, Maxi. Yeah, data rich. Hopefully the videos will help if we went too fast. Please feel free to reach out to us with any questions. We'll both Dr. Meredith and I would be delighted to answer them. Hey, David, maybe I can ask a question.
Please.
So, with oligodendroglioma and the grade 3 designation. Why is it proven so hard to find a cutoff there? So you probably go with use mitoses as your cutoff, I guess 5 or 6 per 10 high powered fields. Is that going to be the most reproducible, or do you still hold hope that CDKN2A deletion is going to give us a useful tool?
Yeah, I think it's probably the latter. You know, I think once the paper on hypermutant gliomas came out, you know, talking about that kind of mismatch repair deficiency, chemoresistance mechanism that Keith's lab put out a few years ago. I think it really kind of underscored the idea that there's just certain genetic mechanisms that are going to make these tumors go very, very bad. And that anything else that doesn't have that kind of genetic profile is probably, it's just kind of irrelevant how it looks. And I think that's the same with oligos and with astros, and why we occasionally see oligodendrogliomas with amplification events and polysomy 7 and -10 and all those kinds of crazy changes, and many of those patients just continue to do very, very well for decades. So I think unless one just really hits the right, or in this case the most awful prognostic biomarker in the genetic profile of a tumor, is just never going to reach its most aggressive biologic potential.
Sounds good, thank you.
Because I know there are some centers that even with grade 2 and 3 astros with IDH mutations, that the difference in biologic potential is so minuscule that there's almost not much incentive to distinguish between the two. So it's I think it's an issue that'll be probed further with bigger studies, I hope. But we may see P16 immunohistochemistry being adopted more widely once some validation studies can be done.
Right, and that's been shown recently. I think by Ari Perry's group, to be useful in meningioma grading as well, P16 IHC in the higher grade ones. So yeah, so maybe that's another immunohistochemistry surrogate for genetics that will be useful as well in that setting too.
Yeah, I think just to kind of wrap things up, I know that we've both presented a lot of genomic information, which may or may not be something that a lot of centers have access to, and I think what we'll find as we conclude this era in molecular neuropathology is that probably the number of diagnostic or prognostically useful markers in each tumor type is fairly limited, such that we may be able to develop a minimal immunohistochemical markers to use in place of more routine, widespread genomic testing. So hopefully we'll see some of those things pan out as time moves along.
Yeah, no, I think that's a great point, because it does seem that, I think that's one of our duties as pathologists, right? We do some complicated testing with these innovative new tools, and then we boil it down to a single antibody, right? An IDH antibody or a BRAF antibody or a P16 antibody. So a lot of it starts complicated, but then can be really actionable and straightforward, hopefully.
Exactly. So to reiterate what Dr. Sandagatis said, if anybody listening live or on the replay online has any questions, feel free to reach out to us with our email addresses that were present at the beginning of our presentations. We hope you've enjoyed these presentations, and if there's any further information we can provide, we'll certainly be happy to do so.
Thank you, everyone.
Thanks much.